that we have in place, or the procedure that we have in place for someone, has been really with safety of students and staff first and foremost, perhaps even overly stringent, and using even hospital level security measures. And that is the reason why all the measures that are in place are in place. That includes the really rapid mobilization and implementation of hand washing, of mask wearing, despite Ministry of Education recommendations of what could have been at that time considered casual or loose or less stringent mask wearing recommendations. Someone has actually been much more aggressive about it. And the implementation of adequate ventilation in rooms and throughout the schools. At the same time, however, it is a school, so it's not a military base. It's not a hospital setting. The goal here is to try to provide an environment that's conducive for students to learn and to thrive educationally and academically and socially. The reason I'm saying that is because, we have with people's concerns. So in an ideal setting of a group of people who are in a group together in a class, you can imagine and you say, well, a mask would provide an extra layer of protection. And that's absolutely true. And that's why there's hand washing, there's mask wearing, there's adequate ventilation, and those measures are maximal measures that we can implement at this point. Every layer of protection is exactly that, a layer of protection, but it is not absolute, right? So that it is not that one layer of protection or one measure of protection is better than others, that they do work in concert. On the other hand, we also have to be, we have to avoid paranoia in the sense that if people are wearing a mask during the time that they are in the classrooms, that's great. But don't forget, there's also the distancing measures, the hand hygiene, and the ventilation. If the masks were to come off, for example, with a mask break, it's not like this massive toxic cloud automatically goes out and starts infecting people, and then you'll start getting some badness like you see in some science fiction movies, right? There is actually good data to suggest what the minimal amount of time of exposures are going to be, so that if we can stay within those parameters, that's great. The staff, the faculty have been very good at mitigating anybody who may accidentally or intentionally deviate from those types of things. So inside the rooms, there are pods, and they're wearing masks, and they're distancing, and their hand hygiene, and their ventilation, and that's great. And we know that collectively those measures will decrease the rate. We know that because, and I don't mean to toot someone's horn, but if you look at someone compared to the performance of other schools, if you look at the metrics by measurement of a number of students affected with COVID, we are really at the bottom of that list, which is good. Right? We don't want to be having a large number of students or staff that are affected. So I think that statistics speak for themselves, that the measures that are in place are good. At the same time, you don't want kids to be undergoing mental health issues or anxiety or anguish or stress or any of that stuff from overly zealous security measures. And so we have implemented measures by which you can have a little bit of breaks. That means going outdoors as much as possible, obviously not now, but when the weather permits. That includes mask breaks, but under very strict conditions. And those strict conditions are not more than a few minutes, and obviously maintaining distancing and hand washing and ventilation and all those other measures. So in an ideal world, yes, all measures should be implemented and consistently applied from the start of the day to the end of the day. And that would be the maximal level of protection. But let's not lose sight of the fact that these are kids, and that it's not really an all or none phenomenon. It's a gradient phenomenon. I'll just give you an example. I'm not wearing a mask now. I'm at the hospital. And the reason I'm that, and even though there are offices all around me, we have not had a case at all on this floor. And that's simply because of the fact that I'm maintaining my distance. I have good air, room ventilation. I maintain good hand hygiene, and everybody else on this floor does that. So the fact that I'm not wearing a mask, even if my door opens or closes, doesn't lead to massive outbreaks, exactly for that reason, because you need a minimal amount of time of exposure, and you need a certain viral load in your respiratory secretions or in the aerosol transmissions to be able to spread to others. So hopefully that answers the question about the procedural masks. In an ideal world, yes, it should be on all the time, especially if distancing, ventilation, and hand hygiene are not optimal. But at the detriment to the kids, we have to balance that it doesn't become, deleterious. It doesn't have a deleterious effect on the kids, and so mask breaks or measures to allow mask breaks are in place. And this is not just unique to Selwyn House. If you actually look at provincial regulations across the country, for example, Ontario, BC, they actually have policies for mask breaks. So, our recommendations or our plans are actually congruent with what's going on, not just in Quebec, but actually across the country. I'm not sure if whoever asked that question, I should say, if that question was answered adequately enough for you, or if there are any questions coming off of that answer.
Yeah, Dr. Vinh, that was from Kathy Funamoto and myself, looking at when we come back in January, whether students should continue, whether we should be asked to wear those blue procedural masks as well as faculty.
Right. So again, I'm going to be honest with you. I think when we come back from the holidays, the community transmission rates are something that we are keeping an eye on. I'm not sure what it's going to look like when we come back from the break. I'm not sure what it's going to look like for the month after we come back from the break. It could actually be a bit of a nightmare. The modeling suggests that it could be disastrous. The government is strongly considering a lockdown. So we're not sure yet, but if a lockdown is not actually implemented, there is a risk for community transmission to occur. There is a risk that children can become infected in the community and bring it into the school or staff. And so therefore, masks should be worn in those situations where, or along with the situations of distancing, hand hygiene, and ventilation. But mask breaks could be developed if done strategically.
Great, thank you.
So the next question I have is, can someone who has had COVID still transmit the virus if they come in contact with someone who is positive? So I've heard different variations of that type of question, so I'll just give you a bit of a context. For the virus to cause us problems, there's 3 important steps that you have to know about. The virus has to attach to our cells, so it has to infect us. That's what we call an infection. It attaches to our cells, and it injects its material into our cells. Once it does that, once it has established an infection, it will do 2 things. One is that it will do what microbes do, which is try to win the battle against the cell. And in the process, we become sick, or we get the disease, we get COVID. The other thing that it does inside the cell is that it makes little hundreds of photocopies of itself and tries to produce them and expel them as virus particles that go into our secretions and lead to transmission. So there's infection, there's disease, and there's transmission. So those are the 3 steps that we have to talk about. What we've seen so far is that once you get an infection, you may or may not get disease. And in the process of that, of the virus trying to establish itself, you get an immune response. That immune response recognizes the virus and tries to eliminate it. And it also develops a memory so that if you should see this virus again, you could eliminate it faster, okay? what we've seen since the start of the pandemic is that you can get infected with COVID, may or may not get disease, may or may not transmit. If you had disease, you could recover. But then months down the road, you can actually get reinfected. In other words, you can get the virus that's detectable again if you get tested for whatever reason. And in fact, there have been numerous reports about that. You have to remember a few things, though, is that some of the cases of reinfection have actually only been identified because the people were being screened, let's say for travel or for whatever reason. So a lot of the people actually didn't have any symptoms, so they didn't even know. So you can certainly get reinfected, but we don't seem to have any evidence that you can re-get disease. But going to transmission now, the question is, if you get reinfected, can you transmit even if you're not well? And the answer is, we don't know. We don't know that because the way to be able to do that is you'd have to test on a massive scale. And as if most of you already know, the policies for testing have changed quite a bit. And so they're not done systematically, they're done based on policies. Sometimes it's if you've been infected, if you've been symptomatic, sometimes if you've been exposed, sometimes if you've, whatever. So there's different reasons why people get tested, but those reasons for getting tested are not systematic. And therefore we don't know necessarily if there's a risk for retransmission, okay? That actually extends a little bit to the same idea with the vaccines. So the vaccines that are coming out in the next month or so are going to prevent you from getting disease. In fact, they're amazingly effective, or the word is efficacious. They're amazingly efficacious in preventing you from getting disease. That means if you get the vaccine, you can still get infected, but you have at least a 95% chance or so of not getting disease, and you have about almost 100% chance of not getting severe disease. In other words, a disease where you need a tube to help you breathe, for example. But you can still get infected. And whether or not you can transmit, we don't know. So these are important questions of, if you were infected before, can you get reinfected? The answer appears to be yes, okay? How often that occurs, we don't know, but it seems to have, there have been numerous reports about it that I can tell you personally, we've seen it here as well at the MUHC. So it's definitely a phenomenon. How often does that occur? How often does reinfection occur? Not entirely clear. And can reinfection lead to transmission? Possibly, but we don't know yet. And as you can imagine, we don't take up somebody who's reinfected and then put them around other people who've never been infected and see if they get infected. That natural experiment would be unethical. So hopefully that answers the question. But obviously it's a complex and charged question. So if you have specific questions on this, I open the floor to anybody. I'm going to take that silence as being no questions. So just go back to the question, can someone who has had COVID still transmit the virus if they come in contact with someone who is positive? The answer is possibly. And so that's why we still have to do all the measures of isolating the person and distancing, hand hygiene, all that kind of stuff. When is the likelihood of having a vaccine for elementary students 5 to 12 years old? So that's an excellent question. As you know, there's 3 vaccines that are pretty close to prime time. One will be rolled out at least. They say the doses will be arriving next week. I'm not quite sure or convinced that it'll be rolled out next week, but certainly by end of January, we'll have a vaccination rollout. The vaccines have been studied so far in adolescents and older, in adults and older adolescents. The data on how efficacious and how safe it is are essentially on adults. We don't yet know on children less than 12 years old or less, how efficacious or safe it is. That doesn't mean that there's a doubt or a suspicion or something sinister that perhaps it will be dangerous or ineffective in children. It just means that we don't know, simply because um, one, in general, clinical trials are not done on children as a first type of subject to be tested unless it's a specific pediatric disease. And the other is that children are not the primary at-risk group. So if the purpose of the vaccine is to prevent disease, doing a study on children who, for the most part, don't get disease is a very costly venture for little bang. So a lot of bucks, not a lot of bang. So a lot of the studies are done on adults because those are the ones who are in need of the greatest protection. I have a colleague who sits on the FDA committee, and he tells me that the 3 vaccines that are being rolled out for adults are actually actively doing studies on children now, as well as in other risk groups like pregnant women and that kind of stuff, so that we will have that data in due course. I suspect probably within about 4 to 6 months, but we don't yet know. And we have to wait a bit longer. The reason we have to wait longer is if the purpose of the vaccine is to decrease the risk of disease, you have to have a certain number of events between those who, or the number of people get disease between those who get the vaccine and those who don't, to be able to make any statistical comparisons. So that's why it's a bit of a slower process. I'm not sure if that answers your question about vaccines in children. I'll go to the next question. My elderly parents both had COVID in November and fully recovered. That's great. Are they now immune? And if they are immune, can they still be vectors of transmission? So that's great. I'll just take a moment for what may seem like a shameless plug, but I am actually the director of the MUHC COVID Biobank. We are one of the major centers that are mandated by the Quebec government to create a biobank for COVID-19 patients. So what that means is that the Quebec government in March or April mandated that all the academic university centers create this biobank where we, all patients who had, all people who had COVID, whether they were hospitalized or not, have clinical data collected and blood samples collected so that it's banked. And then we can do all sorts of cutting edge research to understand this infection and get it under control and come up with new therapies. I only say that simply because if your parents both had COVID-19, we would certainly be interested in recruiting them into the biobank. Are they immune? The answer is, when you talk about immunity, we talk about 2 different things. We talk about antibodies and we talk about T cells. Antibodies are proteins that are floating around in your blood that try to neutralize the virus. You can imagine it's like bullets in a gun. Most of us all had, I'm presuming all of us have had vaccines. When you have a vaccine, what you do is you give sort of like a weakened part of the microbe, or just a little snippet of the microbe, and you train your immune system to recognize it and to produce the weapons necessary so that if it ever sees it in real life, it'll be armed and ready to kill it. One of those arms are antibodies. Okay. The other type of arm is called T cells, and those T cells, they kill the virus through different ways. Antibodies are relatively easy to measure, and T cells are relatively difficult to measure. What we've seen so far with immunity, at least for vaccines or for people who have recovered, is that you can measure antibodies in the blood. And at the beginning, there were some really horrible quality, crappy antibody tests that didn't mean anything. But now, by the way, if there's a diagnostic lab that advertises to you to pay a few $100s for an antibody test, I'd be a little bit cautious because some of those labs are not quality controlled. But eventually we will have antibody tests available. That's under one of the mandates of the Quebec government. And those antibody tests will be able to tell us yes or no if you've had COVID before. We don't yet know how much antibody is required to provide protection. We do know that if you get an infection, your antibody levels go up and then they eventually go down. That happens to be less the case with the vaccines and more the case with the natural infection. But in either way, you get the cells that produce those antibodies. They're going to linger around for a while, and they're going to probably be there to prevent you from getting disease if you do get reinfected the second time. But the question there is, if they had the infection, can they be vectors of transmission? Not during that episode, right? So if they got infected in November and they recovered in November or December, they're no longer vectors of transmission for that episode. We know that, in fact, when you have when you're infected with COVID, you're infected or contagious for about 7 to 10 days. Okay, then after that period, you're not contagious anymore. That doesn't mean, though, that if you get reinfected, you're not contagious. We don't know yet, and that goes back to what I was saying before. So if you do get reinfected, it's possible that you could still be contagious, even though if you don't become sick. And therefore, yes, you can be a vector of transmission in that situation. So just because you had COVID before, that means that at that episode, you're no longer contagious, you're no longer a vector of transmission. But if you do get reinfected, you could potentially be a vector of transmission or contagious, again, on those subsequent episodes. Is that clear? Perhaps it's not clear, and if that's not clear, I'll try to make it clearer.
Yeah. Thank you for answering. That was actually our question. Who, if our parents are interested in the blood bank, who do we contact?
What I can do is we have a lead clinical research coordinator, Anna. I can put you in touch with her, and she can coordinate that with you.
Okay.
You can feel free to perhaps maybe on a private chat, you can send me your contact, and then I will have Anna contact you probably tomorrow or the day after.
Okay, thank you.
So Doc, do you have any more questions?
I do have a few others, yeah. Okay. Is it safe to go up north to ski for the day? Is this even allowed? So I just want to make a distinction here that, I can try to provide answers at least from a medical or a scientific perspective, but not necessarily from a policy perspective. The government is continuously updating their policies on displacements. For example, between alert zones, red and orange, and all that kind of stuff. If you haven't had a chance, you should certainly listen to today's press release or announcements, because they're now coming down very, very strictly they're now just going to forego warnings, and they're going to start fining people. What I don't want to do is give a recommendation on a policy that can change tonight or tomorrow, and then it may lead to repercussions to the person who is following a recommendation that I made that's an outdated policy. So what I would recommend is, if you just Google COVID in Quebec and you go to the quebec.ca website, you'll be able to find in English, actually in French, the latest policies, and then they're actually kind of self-explanatory. What I think people should be cognizant of the fact is whether or not we're talking about skiing, is when you go out, this is not the time to be complacent. That, with the vaccine rollout in the next month or so, we're probably going to start to see an effect of that vaccine on transmission in the community within about 4 to 6 months. Okay. So I think we should be ready, that there's no magic bullet that's going to change anything overnight. And the reason it's going to take a while is, one, you have to get the vaccines in, and the vaccines come, at least one of them comes from the US, and there's a guy down in the US who's a bit, ornery, and right now he's causing some problems for access of those products. Then there's going to be a rollout, and at least with the Pfizer vaccine, there's some infrastructural challenges that are going to need to be addressed, and then there's prioritization, right? So all of that to say is that by the time this vaccine is ready for the entire community, it could take a while, and the effects will only happen after that. So what that means is that with the vaccine rollout, we will still need to adhere to distancing, mask wearing, ventilation, and hand hygiene for a while, for months, okay, before we can re-invoke the question of when can we return to any sense of normalcy. I know that's perhaps not what people wanted to hear, but I think if we can mentally brace ourselves for that, that may put us in a better mental state of mind. So, so just to give you a timeline, if the vaccine starts to roll out at the end of January, probably February, March, it escalates. So you can imagine somewhere around August, September, that we'll be able to accumulate evidence on how effectively we're controlling it, at least in our communities, which is great because that's almost in time for next school year. So I don't have any other questions that were sent to me, but I don't know if there are any either burning questions or.
Yeah, I have a few in the chat here.
Oh,
first one is, what is the probability of virus spread if individuals are in a poorly ventilated environment where someone has the virus, but everyone present is wearing a mask and maintaining 2 meter distance from one another?
So that's a great question. The evidence for aerosol transmission actually comes from what we call the natural experiment, where people weren't wearing any of that. So, for example, in restaurants or in, choirs or at some presidential gathering at the White House, those sort of things. What we can not do, and nor I think we would ethically do, is do those experiments where we say, okay, we're going to take somebody who's infected and contagious, and we're going to put them in a room with other people who are only wearing masks or only ventilation, or ideally, we would like to have those controlled conditions to be able to exactly answer those questions. But you can imagine that won't go well for some people, right? And so we don't know. What we do know, for example, though, is that if you wear a mask, your risk of either transmitting or infecting is very low. If you distance yourself, so for example, if you distance yourself 2 meters or more, your risk of either infecting or transmitting is about 3%. If you are less than those 2 meters, it's about 17 to 20%. If you look at masks, it goes from about 3% to about less than 1%. So you can sort of do back of the envelope type of calculations, keeping in mind that this is not all additive. It's not like grade 8 algebra where it's x plus y plus z, right? Some of these things are a bit synergistic, and so it's not necessarily the addition of one or the other. But we can't tell you necessarily that if you have 2 out of the 3 things on your Chinese menu, do you still have a good lunch? We don't know. But what we do know is that if you have the perfect storm of all of those conditions where you have distancing, you fail to obey distancing and mask wearing and ventilation, then things are bad. We also know, for example, in those situations, like for example, in the Korean restaurant or in the US choir or any of those things, that people who were infected were more than 2 meters away. So but for example, at the presidential press gathering at the White House, most people are 2 meters away because you can't get within 2 meters of the president. And yet we know that that was a super spreader event and there were a lot of people who got infected. In the Korean restaurants, so the Korean CDC has actually published quite a few reports about this. And these are people who are, I mean, they're not even sitting together. They're not even, acquaintances of each other, sitting in different parts of the restaurant, and yet they got infected. So all that to say is that we just know what happens when none of those measures are in place, and we can attribute it to certain parameters, but we don't have yet those, nor I think will we ever have those types of conditions where we have only one measure and determine its effect, or only that measure and determine its effect.
Okay, in the first wave, masks were not required or prevalent, and people were only beginning to get used to social distancing. Now masks are being worn by almost everyone. People are practicing social distancing. Social contacts have certainly been reduced, yet the number of cases is as high as ever. How can that be explained?
Okay, so in the first wave, why were masks not recommended, I think is the first part of that question. And you have to remember that in the first wave was around March, April. So that's about 9 months ago. In the 9 months, or 8 to 9 months, what we have understood is that there's an increased risk for what we call aerosol transmission, particularly in areas with poor ventilation. The other thing to remember in the context of the first wave was that it took the world by storm. And so there was a massive shortage of personal protective equipment, or what we call PPEs. And there was a massive increase in the number of people who were being hospitalized. And so there was a rationing of personal protective equipment at that time. And that was one of the, so the lack of knowledge about the transmission, the lack of appreciation of aerosol transmission, and the context that we needed to ration personal protective equipment for frontline healthcare workers who were in the face of these people who are presenting with disease, were the driving factors for why masks were not recommended at the time. Masks are recommended now. And so the question is, well, then why are we still seeing secondary cases, or why are we still seeing cases during the second wave if masks are recommended? And that's because adherence is poor. Adherence is crappy. There are, if you look at the places where there have been an increase in the number of confirmed cases, they have been, a lot of regions are outside of Montreal. So for example, the Saguenay-Lac-Saint-Jean area, the Gaspésie area, the Lanaudière, Montérégie area. This is all available on the Quebec.ca or Quebec.gov website. And the reason is because of complacency and lack of adherence. So even though the government can recommend to wear masks, there are clearly people who are not wearing masks. I mean, there are people who actually celebrate the idea of not wearing masks. They actually gather in shopping malls to not wear masks. They gather in bingo halls to not wear masks. Rimouski had some sort of like pornographic orgy in a bar that had to be cracked down by the police. So there is gross disrespect for adherence to the mask, and that is why we are actually seeing ongoing cases. There are actually, on social media, there are people who say they don't need to wear masks. It's a violation of their liberty, and which, by the way, it's not if they were actually read the Federal Public Health Act. But the other thing is they say, well, mortality rate is less than 1%. Which is a flawed logic, because one is if you go to the CHSLDs, the mortality rate is somewhere between 50 to 60%. And the other thing, of course, is that only looks at death and not hospitalizations. And, for example, we're at 850 hospitalizations in the province for COVID-related cases. That's 850 beds that we cannot use for other medical care. So So there is actually a gross disrespect for the recommendations for public health measures. And that is the reason why we're seeing ongoing cases.
All right, thank you. Now, what is the plan to deal with vaccine hesitancy?
You know, if there was a plan to deal with vaccine hesitancy, we actually wouldn't have to deal with vaccine hesitancy, because vaccine hesitancy is not specific to COVID. It's sort of, you know, for lack of a better word, sort of a cult-like mentality. You know, I think we have to make a distinction here. There are people who have legitimate concerns about vaccines, but the best way to overcome fear is with education. But then there are people who are sort of, you know, there's an impasse in their ability to be informed, and they are fixed in their beliefs. So for the first group, where you know, fear can be overcome by education, what I would recommend is, first of all, your fear is legitimate, right? Because you're talking about a new type of vaccine for a new bug, and you know, you can have a lot of question marks about how did this happen so fast, and all these things. What I would recommend, though, is that you educate yourself, either through listening to people who are familiar with the process, or perhaps on your own, but through reliable sources, and hopefully you'll see that the information that comes out will allay your fears. For the people who are you know, steadfast in irrational thought, it's not an easy answer, because those are, you know, people who also don't believe in other types of vaccines. It's a bit paradoxical, because you know, a lot of people are anti-vaxxers, still send their kids to school. So it's a bit paradoxical, because they somehow believe in the educational system, but they don't believe in science, which is a product of education. It's a bit of a contradiction. It's an oxymoron, frankly. And it's the moron in the oxymoron that becomes a danger to the rest of society. But vaccine hesitancy is one of those things where there are actual recommendations on how to have communications with people who are vaccine hesitant and anti-vaxxers, and try to have an intelligent discourse. The alternative approach to keep in mind is that for a COVID vaccine, there won't be a mandatory vaccination, but there will be sort of an indirect advantage, right? In the sense that certain activities that are normal for society, such as travel or returning to work, may only be permitted if you can document or provide documentation that you've actually been vaccinated. And in that way, it's not mandatory, it's not being forced on anybody, but if you want to gain, you have to be able to give.
Thanks, Don. Could you ask about post-COVID syndrome? Is it a real diagnosis or just long case of COVID? Is there much known about it?
So, you know, that's a very interesting question. And the reality is that the short answer is we don't know very much about it, obviously, because it's a new disease, right? We do know that the majority of people who get COVID will either have few symptoms that are significant enough that require hospitalization, or if they do have hospitalization, they will recover, except if you're in certain at-risk groups, where there you can have life-threatening disease. What we're recognizing more and more is that there are these weird syndromes that you can get with COVID, something that in the recent past have been called Kawasaki-like disease or multi-inflammatory syndrome, which can affect children or adults. And that's a bit of a funky syndrome that I don't have time to get into, but that we are certainly studying. But then there's also what has now been called the long haulers. And that's probably not a great name, because for me, a long haul is a very long puff of cigarette smoke, which is not good for your health anyways. But the long haulers is the term that's been used for people who have documented COVID infection, but seem to have lingering symptoms that are, for the medical community, a bit tough to objectify. Things like fatigue, things like brain fog. I mean, brain fog is not even a scientific term. So how do you even define it, and how do you measure it? So those sorts of things. So there's an increasing recognition for these symptoms There are even long haul clinics being developed to better understand it. As part of the biobank that I was talking about before, we have longitudinal sample collections out to 2 years planned. And so hopefully we can help shed insight into some of the stuff, but for the moment, we don't know. We can't really define it. We certainly don't know how to manage it well.
Thanks, Don. Are these alcohol-based hand sanitizers safe over a long period of time?
Yes. So alcohol-based sanitizers have been used for decades in the healthcare industry. Nobody has gotten drunk out of it, which much to my chagrin on some nights, I guess. But nobody has, and the worst that can really happen is that you'll have a bit of a dry hands, in which case you can consider using sort of hand moisturizers for it. Of course, you have to remember that these are commercially made, so commercial grade, commercial quality hand sanitizers. There are people who try DIYs or do-it-yourself type of hand sanitizers, and that's usually a recipe for success. It's perhaps not as complex as neurosurgery, but if you wouldn't do neurosurgery on yourself, I don't think you should be preparing your own hand alcohol sanitizers and using it on yourself or on others.
Thanks, Don. Is it known yet if the vaccine is safe for people who have asthma or pre-existing respiratory condition?
So excellent question. The short answer is it appears so. I do have to say that up until this morning, we didn't know of any group that shouldn't get the vaccine if they were at risk, right? So if you were, let's say, an elderly person or a frontline healthcare worker, up until this morning, the plan was that those people would get the vaccine. What we have found out, at least from the UK, is that there's been 2 healthcare workers who seem to have some sort of allergy problem, and then they had a significant but not necessarily severe allergic reaction to the vaccine. And as a result of that, it's now become sort of a policy to say, well, if you have significant allergies, so allergies to drugs and foods and all sorts of things, then we're going to hold off on giving you the vaccine. And that's the natural process of what happens when you take a product like a drug or a vaccine from clinical trials out into the real world. You learn things. But the fact that within 12 hours or within a day of those doses being started, we already were vigilant enough to monitor for these types of reactions and now have changed policies is actually quite reassuring. Asthma, so asthma in itself, unless you've had life-threatening asthma in itself does not seem to portend an increased risk for severe COVID, which is reassuring. And there is no data now at this moment to suggest that people who have asthma will have an adverse reaction or a bad reaction to the vaccine.
After an exposure to COVID, how long would it take to be positive with a COVID test? Can you be tested too soon?
So if we're talking about the COVID test, you mean the one where they take the nose swab and they look for the viral RNA? That's by using a test called PCR, which is the test that we offer now across the province. The answer absolutely is yes. In fact, what we know is if you were exposed to somebody who had COVID and got infected from them, your chance of getting a false negative test, which means that the test says you don't have COVID, but in fact you do, okay, is almost 100% within the first few days of being exposed. And then as we go out from there, so 3 to 5 days later after that exposure, the likelihood of getting that false negative test goes down. In other words, the likelihood that your test will become positive increases. So all that to say is, if somebody says, well, I was exposed to somebody this morning, and I'm going to go tonight to get tested, you could, if that's what public health recommends you to do, but don't be complacent about a negative test. I do want to just bring out one issue about the test. The test was developed rapidly throughout the world, as you can imagine, right? So all the countries were developing tests based on the same idea. The test is useful if it's positive. If you have a positive COVID test, dollars to donuts, you have COVID, or you have the SARS-CoV-2 viral infection. Whether or not you have disease, that's a different question, but you have the viral infection. So a positive test is useful. It tells you your diagnosis. A negative test does not exclude the possibility that that you have the virus. It's like, I'll give you another example. You know, it's like doing an X-ray of your lungs. If you see a cancer, then you probably have cancer. But if you don't see a cancer, it doesn't mean that you don't have cancer. Okay, so you can use that same idea, that same understanding. So the test, if it's positive, is useful. If it's negative, it's not useful. And that's because there are a lot of factors that go into how the test is performed. You can imagine, I've had it done on myself. So if you've had it done, you know that you're getting that furry stick in your nose for 10 seconds. And you can't move for those 10 seconds, even though somebody's tickling the back of your brain and you're crying and your nose is running, okay? But you can imagine that if you sort of don't comply properly, or that stick is not in deep enough or not rubbing enough of your cells, that test is not going to be super great in terms of, or super reliable in terms of its results. And so that's why there's a lot of other factors, but a negative result does not exclude the possibility of having the viral infection.
And why don't we use the rapid tests in Quebec?
So in fact, the rapid tests, there are different kinds of rapid tests. So I just want to clarify that there are different kinds of rapid tests. And the rapid tests are actually being used in some situations. But the rapid test doesn't have as good a, what we call a test performance characteristics. In other words, it's not as good as the PCR test. And so depending on your depending on the group of people you're testing and their likelihood of exposure and the reason you're testing, that will determine what kind of test you want to use. So it's not like, you know, if you go to Selwyn grade 8, or if I go to Maimonides CHSLD, I'll use the same test. The risk before you even do the test of exposure or infection are different. And so you want to make sure that you use the right test in those situations. In the situations like in the community where you have a moderate level of probability of having been exposed or infected, you want a very sensitive test, a test that can pick up as small amounts. Because you want to know if that's positive, right? Because that will have implications for that person who tests positive. But if you have a situation where there's rampant circulation of virus in a certain environment, then a test that has high sensitivity is not absolutely necessary. And so you can compromise a little bit on that sensitivity, and that's what rapid tests do.
Okay, so I did a long string of chats here. There's a follow-up to one of the questions I asked earlier about the idea with the first wave where we didn't have to wear masks and we social distance, and now we seem to be stricter, but we have more cases as ever. The question you wanted to ask, so I guess you're looking for clarity here, is why are there more cases in the second round?
With Info Santé and explain to them that child X went to go get tested and was informed or instructed to come back the next day or whatever, 2 days from now. And what should I do? You know, Info Santé, I have to say, has also been overwhelmed by this pandemic, and has had to lead to massive training of people who've not worked in Info Santé before. And of course, there have been multiple policy changes as well. And so if you take those factors into consideration, and of course, Info Santé is not connected to the hospitals where the tests are done. And so they're a bit dissociated from that. And of course, the hospitals sometimes have their own policies, right? So I think that's, it's a bit of an example of the fragmentation of our healthcare system. But what I would do to err on the side of caution is to inform Info Santé so that they are aware with any of the recommendations that they make to you going forward based on the fact that the testing was delayed.
Thanks, Mike. Thanks, Don. Mike's back. All right, Mike, good to see you.
I don't know. I'm actually at school and I'm using our internet system and I'm not even on wireless. I'm plugged in and I got kicked off. I lost any questions that were in the chat. I don't know if there's still some there, Mike.
I don't have any. I just want to let everybody know, maybe we'll take one more question or two at the most. Don's got about four minutes left, and I know he's got a very busy schedule. So if you can kind of wave your hand or fire a question into the chat for Mike, I think he might get a new one back in, or shoot one into me. I'm happy to pass it on. From what I can tell, looks pretty quiet.
Well, let's wrap it up then. Listen, on a personal note, and on behalf of Sel and Don, we just want to thank you so much for both your time tonight and your time over the last 6 months. You have been so valuable to us. So thank you very much. We really do appreciate it. If anybody does have any questions that come to mind that get answered here, please email them to myself or Mike or one of the division heads, and we will make sure we get that out to Don. There was one question I got in the chat, Don, that was complimenting on your articulateness and how good you were at explaining things on a nice, simple level with a little bit of humor in there. So I really did appreciate that.
Great. I hope, the whole value of this is really to educate us as a community. So I hope that was accomplished. If you have any questions that you think requires a little bit more clarification, that just means I need to explain it a different way, and feel free to reach out to me.
Okay, super. Thank you so much, Don, and have a nice evening. And thank you for all that you and the people at the hospital are doing, because you guys really are heroes.
Thank you.
Thanks, Don. Class of 92, eh, Don? Way to go, man. Good job.